Next, Ben Scirica returns, this time with Dr. Ileana Pina, Associate Chief of Academic Affairs at the Montefiore Medical Center in the Bronx, New York. They cover, should we use high-intensity exercise?
Well, thank you, Ileana, for joining us at ACCEL.
It's my pleasure to be here.
Why don't we start off and just define what high-intensity exercise is?
High intensity essentially is you're getting to, say, 80 to 90% of your maximum capacity. And you can define that as VO2, or you could define it as heart rate, but you have to be careful because patients on beta blockers may not get to very high heart rates. Or you can define it as a percentage of the ventilatory threshold. And in general, the high intensity is maintained for several minutes, like let's say 3 to 5 minutes, but it's followed then by about 3 minutes of recovery. So 3 minutes where the patient can kind of adjust to a lower level. You don't stop them. You just bring them down to a lower level, and then you bring them back up again. And you do that for about 45 minutes. That's one of the modalities.
And what are the physiologic benefits or potential risks from that degree of exertion?
Well, nobody really knows what the true risks are. I think everybody has been very comfortable with doing moderate to vigorous because we have much more data and we know it's been safe. We think that it triggers, certainly in normals, it may be enough to trigger the physiologic changes like peripheral adaptations, which includes muscle changes, improvement in redox potential, improvements in endothelial function. And there's some data now, even with lowering BMP, which we're all, very concerned about right now. And that's what in general has been thought. I think the fear is that maybe you're going to drive, for example, catecholamines higher and these patients can have arrhythmias. Certainly with moderate to vigorous SNHF action, we did not have a single ICD firing. And of course, the ICDs follow the heart rate. So there's been fears, but in 3 or 4 studies so far that have come out, it's not there. We don't see the same risk. So maybe it works.
And remind us the degree of heart failure that you had in ACTION HF. Who are the patients that you were putting under this type of regimen?
Right. So in HF Action, we had opened up inclusion to New York Heart Class 2 through 4, even though it was primarily 2 to 3. Ejection fraction less than 35 and at least 6 weeks after any event, which would include an MI or the placement of an ICD or bypass surgery, but it was also a superbly medicated population. We had 95, 96% renin-RAS inhibition, and we had 95% beta blocker. And our mean beta blocker, if we equate it to carvedilol, was 37.5, which is a pretty decent dose. Very well medicated. And we have data that in the patients who performed a volume of exercise between 5 and 7 METs, there was actually a positive correlation with the endpoint. Of course, it's a post hoc analysis, but it looks really good at that level, and that's what we call volume of exercise.
And is it more than just a marker of those patients that have better exercise capacity, even though they may have the same ejection fraction, or is it the quantified improvement in their symptoms over time?
It could be a combination of those things, and maybe people who were in better shape just did better anyway, but our mean peak VO2 in the study was 14.9. We did not have the rocket workers that were doing so well. A lot of those patients fell below 14. Are you going to transplant them all? Heavens no.
So practically, how would you approach a patient with class 2 to 4 heart failure who's well medicated that you wanted to try to get into a more vigorous exercise program?
So now we have the ability for Medicare. Medicare is now covering heart failure with some stipulations, basically the same entry criteria as HF Action. And generally what I say to the patients is walking is a very cheap form of exercise. All you need is a good pair of shoes and a comfortable environment. And if they can walk 20 to 30 minutes to the point that they feel like they can still have somewhat of a conversation, that the rate of perceived exertion is somewhere between 14 to 17, so they feel like they're doing moderate to hard work, that may be sufficient. And that was what we used in HF Action. I think until we see if this higher intensity, which in fact increases peak VO2 more than moderate, will it really translate into survival benefits? We haven't seen survival benefits yet.
And what are the studies that are continuing on that?
I know that there's one large study, I think primarily being done in Europe, using the high intensity. Right now, there are some other smaller studies that have compared high intensity to moderate intensity. But as before HF action, they're smaller. They're basically single center, and people don't report their negative stuff.
No, I think that's right. And I think that's the same even in non-heart failure populations when they look at high intensity versus either normal intensity type exertion. As opposed to cardiac rehabilitation after cardiac surgery or after MI, for heart failure, are there any differences in terms of the goals of the frequency or the duration? Is this it's a lifelong disease. Should this be lifelong programs?
Well, I have an editorial that says exercise should be a lifelong commitment, but it should be. The problem that we had was adherence. And patients don't like to exercise. Normals don't like to exercise. So if you can get them into some kind of program, starting somewhere where they're with others like them, because I do believe in the power of the collective thinking, that they may adopt this for the rest of their lives, particularly if they feel better. And certainly we know their quality of life gets better. So if you can have them buy into that, what we still don't understand is human behavior. And what are the behavioral components that are going to tell me this is somebody who's going to be adherent and here's someone who is not, no matter what I do. So you got to make it feasible and maybe fun. You know, if they don't feel like they're having a good time and it's work and they're uncomfortable. I mean, you and I know that moderate exercise is not comfortable. I do spinning now. When I get off the bike, I can barely walk, but you feel good.
I think you're right. It's trying to find those tricks, whether that's when you let yourself watch TV.
Whatever watch the news, read,
exactly, whatever
read a
it is.
book.
A lot of patients I see are fearful of exercising. How do you help get them over that fear that they know they have a heart condition, which are taking all these medicines? Their relatives seem to be afraid when they lift a half full plate that they're going to overexert themselves. What type of counseling do you give, or even reassurances?
I often tell them when you get deconditioned, it's very hard to tell whether you're just out of shape or it's just your heart failure symptoms because they feel the same. So you have to tell them that they will get short of breath when they're exercising, and maybe that the day later they're going to feel like they've been beat up, but that's okay. And it's perfectly safe to do so. Whenever I do the cardiopulmonary test, which is what we do in heart failure, I have a family member there who can actually see that their loved one can actually walk more than they would allow them to. Back years ago, actually, when Dr. Beauvais and I were together, we had a woman whose husband would carry her down the stairs because he was so afraid of her doing anything, and it was newly diagnosed. And of course, you know, we broke that myth very quickly. Please leave her alone. Let her do whatever she wants. So I think reassuring them that, yeah, you're not going to feel as well when you're doing it, but it's perfectly safe. And that's part of the benefit. It's like the beta blocker. You're going to be a little fatigued, but stick with it because then you're going to feel better if this works.
The more you do, the more you do, and the more
you do, and the better you feel.
Exactly.
Yeah.
Well, great. Well, thank you so much.
That was fun. Thank you.